Opik, and I'm doing my presentation on ALS. What is ALS? This is a muscle fiber atrophy disease that is impacting the brainstem and the spinal cord. The part of the brain that's impacted is the motor cortex. It's a progressive muscle paralysis disease and is a fatal disease that is neurodegenerative. What is the effect and who is affected? Survival time is usually 20 to 48 months. 10% of people go longer than a decade, but that's very uncommon. It usually affects 58 to 60-year-old people. Men is more common than women, and higher cases are found in Europe. History of ALS. It was discovered by Jean Martin Charcot. He was the first to diagnose ALS in 1869. He described it first and discovered the symptoms. It's called the Charcot's disease, the Lou Gehrig's disease as well, a New York baseball player who died of ALS and became well known for the disease. What is the microbiological breakdown of ALS? On the right we have the diagram here looking at the dysfunctions of what occurs that lead to ALS. Contributors of cellular dysfunction: endoplasmic reticulum, protein folding and accumulation due to genetic mutations begins to overload and stress the endoplasmic reticulum. This results in motor neuron death. In mitophagy, gene mutations disrupt this process. Accumulation of failed mitochondria buildup and damaged motor neurons are the result. In autophagy, the body breaks down damaged cells, and as well as going along with these other two forms of dysfunction, it just adds to ALS becoming more of a problem. Mechanisms of ALS. On the left we have a normal nerve cell, on the right we have a nerve with sclerosis. Here the signal is having trouble going down the neurons because they are dysfunctional and degenerative, resulting in the muscle unable to contract because the signal is having trouble getting through. Genes and proteins that are associated with ALS. On the left, we have a list of some of the genes that are most related to ALS and the ones that have been studied the most. There are a number of genes and proteins that have been studied overall. They are all linked to insufficiencies, mutations, variants, and dysfunctions. But the ones that are listed here causes neuroinflammation. In the SOD1, 170 mutations are associated with ALS, and they cause motor neuron death as well. These other two are also heavily studied in this idea. Causes of ALS. It's unknown, but these are some potential suggestions that people have had: head injuries, certain viruses, enterovirus, retrovirus, exotoxins, lysosomal and dorsal system and immune system diseases, and disorders such as autoimmune. These are suggestions, but there are many types of ALS that have been studied. ALS with cognitive impairment, behavioral impairment, both of them at the same time, dealing with dementia, Alzheimer's disease. Sporadic ALS is non-inherited, so no one in the family has had that before. Familial is when somebody in the family has been affected, and that's only 10% of cases. And then there's also ALS with spectrum disorders. And then there's spinal, which is upper and lower limbs being affected, and bulbar, which is facial muscles and dealing with weakness. This results in a lot of times slurred speech, trouble eating, things like that. There are different therapies and testing for ALS research. Tests are often done on mice. These therapies are being tested, but none have been found effective in curing ALS. Trials use small molecules, mitoglial activation inhibitors, antioxidant therapies, gene therapies, stem cell-based therapy, and mitochondrial protection. Symptoms of ALS, they include paralysis, awkwardness due to muscle weakness, tripping or stumbling, problems with gait, slurred speech, problems with eating, poor posture due to muscle weakness, muscle cramps, and other things. These all are effective in diagnosing ALS when they are seen. Initial symptoms include asymmetric weakness, wasting of limited muscle groups, development of spasticity, beginning in the upper limbs usually, and the progression of this is paralysis and then eventually death due to the muscle weakness. and respiratory failure. Usually the bulbar onset is 2 to 3 years, while the typical limb onset variant is 3 to 5 years. This is probably due to the upper limbs being affected first, and then it is moving down the body, and the bulbar onset dealing with the face is much closer to the lungs. Management and medications. Again, there's no cure for this. Treatments can slow the progression, ongoing trials to discover more medications, but the two that are most commonly used are only modestly slowing progressions down. The riluzole and edavaruzone, they don't cure it. Mechanism is not fully understood, but a lot of it is guessed to have something to do with the antioxidant properties within these medications. With a little bit of background on ALS, we're going to look at exercise effects on ALS. Some of these effects due to different studies that have been done and research methods. The results of them have found that increased mobility is a result, quality of life, respiratory function, increased muscle power, oxygen consumption, less fatigue, protects motor neuron functions, sense of well-being is improved. This one's specifically important because ALS has been known, the lower your well-being, the more aggressive the disease can be, so increasing this is very important. It also may preserve lung or limb or trunk muscle strength, which are the parts of the body that are affected by the spinal ALS. Exercise is a regulator of ALS because it regulates the neuroinflammation. Some of the recommendations are moderate exercise. We don't want high intensity exercises. We don't want to stress the body more and cause more muscle fatigue and weakness. Running and swimming were great low impact exercises to be done. This could also be cycling, a lot of seated bikes, stuff like that. 2 to 3 days a week is effective. You can do more than that, but there wasn't a ton of research suggesting that it was super beneficial. 30 to 40 minutes per day, but this is so dependent on the stage of ALS that you're in. The higher the stage, the probably less your body is able to do due to the muscle weakness, so that has to be considered severely. In this case study, this is a male 58-year-old person. They are diagnosed with sporadic ALS 12 months ago. Medical history, there's no family history of ALS, no other relevant medical issues. Medications they're taking are the riluzole, which is slowing the ALS progress, and to help with the muscle spasticity they're experiencing, they're taking baclofen. Antidepressant is not consistent, but it's trying to balance out the mood swings. As we talked about, having a high well-being and a positive well-being is really important for ALS. We did an evaluation. A physical evaluation led to discovery of lower limb weakness, gait struggles, loss of motor skills, mild to moderate spasticity in the legs, difficulty standing, muscle tightness, and slower reaction times. Cardiac health was pretty good. There was normal heart rate, normal blood pressure. VO2 max was not able to be determined because we don't want to stress the respiratory system more than it's already being stressed by this disease. The respiratory function had no respiratory distress at rest, but then mild dyspnea when physical activity was performed. Psychological status, the anxiety of the disease about disease progression was causing some detriment to the overall well-being of this patient, and inconsistent depression was also something they struggled with. The goal of this patient was to enhance the quality of life through exercise, prevent ALS symptoms if possible, maintain or improve functional capacity of daily living. And they would need to be cleared by a medical professional who's dealing with this disease, just to understand what they're dealing with ALS and healthy standards that they should be considering when exercising. Exercise tests that we should consider are aerobic. We're going to do a 6-minute walk test to measure endurance, oxygen consumption, aerobic mobility, respiratory capacity. We want to be careful because this person's struggling with balance and gait, so we will have railings so they can hold on to if they need to. We're going to use an RPE scale of 1 to 10, so a measurement of 3 to 4 is kind of what we're aiming for. Resistance exercise test is a 1RM test. We'll modify it if we need to. We'll use a submaximal test. We'll do a leg press since there was weakness in the legs and spasticity in the legs, and we'll use the bicep curl. Flexibility testing, we're going to use the goniometer measurements. The sit and reach will modify this since there was tightness in the lower limbs. We'll have a seated sit and reach test with the bent knees to modify for the hamstrings and lower back. We're also going to do a balance test. We're going to do a single leg stance. This is going to work on static balance. We're going to use a spotter for this to ensure that there's no falls to be concerned about. Exercise prescription for aerobic exercises. We're going to do 3 to 5 days per week just to get consistency in. VO2 max was not determined, so we're going to be using 50 to 60% of heart rate reserve. We're going to use an RPE scale of 1 to 10. Again, we're aiming for 3 to 4, 10 to 15 minutes, and we'll increase this if tolerated. Type of exercise is low impact. We're going to do stationary cycling, recumbent biking, arm ergometer, things like that. For exercise prescription of resistance exercise, 2 to 3 days per week, we're going to do low load, so 50 to 60% of the 1RM, and we'll adjust that with the submaximal testing if that was used. 10 to 15 minutes. We're going to do 2 sets of 8 reps, and we'll progress with toleration. Maintaining strength and range of motion is the goal here, so we're going to do seated resistance exercises with the bands. We could do weighted seated exercises. This is just limiting the stress placed on the full body as they're lifting weights or using resistance. Isometric contractions are great, hand exercises, and then we have some exercises listed there at the bottom. For flexibility exercises, we're going to do 7 days per week. This is super low stress on the body and great for mobility, so we're going to do this every single day. Stay within comfortable range. This should not be super intense. There shouldn't be any pain being felt here. We'll hold each stretch for 20 to 30 seconds, 2 to 3 times per muscle group, and then we'll increase that with toleration. Stretching for joint mobility, we can do the calf stretch, hamstring, back stretches, quad, all of those things are great for flexibility exercises. We're also going to do balance exercises 3 to 4 days per week. We want to begin with really easy exercises and we'll progress to things that are a little bit harder that use more muscle groups. 10 to 15 minutes of this. We will also incorporate in proprioceptive training, so we can stand with our eyes closed, work on balance, but making sure that we have spotters there. We're being aware of this person's struggles in this area. Single leg stance is a great exercise for this as well. Breathing exercises will be incorporated since respiratory system failure is usually the cause of death here. So 2 to 3 times days per week we're going to do this. We don't want any strain or discomfort here. This is a really relaxing exercise time, 5 to 10 minutes, diaphragmatic breathing, really deep and relaxing just to work and utilize those muscles for breathing so we can strengthen those. Some precautions and modifications we should consider: fatigue, muscle weakness, spasticity. During and after the workout, we should look for changes in the disease. We should incorporate longer rest periods if necessary, and we should be checking in with other doctors that are also treating this disease so that we can accurately prescribe exercises. We should encourage the patient to listen to their body. We should use assistive devices if necessary. We can switch to machines if that's more helpful. We want to make sure there's supervision at all times so that it limits the concern for falls risk. Encourage emotional and mental support with this, professional help, support groups, those type of things. Monitor respiratory function, avoid high intensity as we talked about, and respiratory overload. ALS, the conclusion of this is a fatal disease, needs to be more attention going to research and trials for cures, since this is something that does not have that already. Exercise can help prolong the life of the person and improve quality of life, and so it should be implemented in treatments of ALS, and more research should be done on the type of exercise and details on how to prescribe it so that this can be more effective. And lastly, here are my references, and that's it. Thank you so much for listening.